let's get into a health conversation. And this hour, we are joined by Dr. Kireki Omanwa. Dr. Omanwa is the president of the Kenya Obstetrics and Gynecological Society of, we already said Kenya Obstetrics and Gynecological Society. And he's here because we want to talk about high mortality rates, high maternal mortality rates in Kenya. Very many women are dying at the point of childbirth. Why is this happening? Daktari, good morning.
Good morning.
Karibu sana to Kenya's biggest conversation again.
Asante sana.
Good to have you back.
Thank you, sir.
Yeah.
It's always good to come back.
Very good.
To the hot seat, as you call it.
Yes. It's a hot seat of the situation room.
Yes.
And it's good to have an obstetrician again.
Yes.
Yes.
Obstetrician. Yes. Siti, yes. Give Dr. the day's proverb.
This is our final proverb from the country of Mali. Okay. Success sometimes is disguised as a disaster. Put on hold.
Success sometimes is designed as a disaster. Put on hold.
Yes.
That sounds quite philosophical.
Yes. Sounds proverbial.
It does.
Mm-hmm. What's your interpretation of it?
But as you have presented it, and in connection with the topic that you want us to talk about, I think in the same vein, I would say success in terms of a woman getting pregnant, and then unfortunately that success ends in a disaster. And unfortunately that does happen day in and day out, not only in this country, but in most countries, especially sub-Saharan Africa. But I'll start by giving just a short experience which I had 3 weeks ago. I had finished a procedure in one of the theaters in one of the hospitals. And then as I was going out to go and change, my colleague, an anesthetist, comes and calls me and say, please come. One of your colleagues needs assistance, another obstetrician and gynecologist. She has a horrible PPH. PPH is basically postpartum hemorrhage. So I walked into the theater. I saw my colleague is struggling. So a quick, review tells me this is a 30-year-old patient, her first pregnancy. She has delivered a baby girl and everything was fine. And then after delivery, she just could not stop bleeding. So she had struggled, she had put this, she had done this and whatever. And we have been trained at a certain level, you know what to do, even without thinking. So automatically I asked my colleague, the anesthetist, have you given this, have you given that, have you given... They said we have given all the medications, which was okay. So let us go back and analyze and try and see what the problem is. So we check with my colleague again. He said, I have checked, but it's good for you to have a second look. So we look at the cervix. The cervix is the opening of the womb, because there can be tears. If there's a tear there which is not taken care of, the woman can continue bleeding. So we check the cervix is intact. We massage the uterus, because usually after delivery the uterus contracts normally. And then taking into consideration that she had gotten so many medications, it was contracted. But where was she bleeding from? Because she was actually bleeding like a tap. We'd put in you would put in what we call an abdominal gauze to stop the bleeding, and then after a few seconds it would be completely soaked.
Wow.
So I put in my hand, checked, I could feel a structure fibroid in the uterus. So my thinking was that possibly this is where she was bleeding from, and possibly the placenta was actually lying on that fibroid. Now that it had come out, it had exposed vessels and they were bleeding, and there was no way the uterus was going to contract on that vessel. So after the medications, but she's still bleeding.
Wow.
And guess what saved the day? A condom. It may sound frivolous, but it was a condom. So he said, do we have a condom somewhere? He said, we don't have a condom in theater because you don't expect to have condoms in theater. But luckily, one of the nurses went around, rummaged around and found a condom. And she came with a caveat and said it was not in my handbag. But
even in such times, it's important.
It was in her handbag.
So what we did, we took a pipe which we call a catheter, and this is a pipe which we insert into the bladder, especially when we are doing surgery. We took that pipe and tied the condom to it and inserted it into the womb, and then pumped in about 300 milliliters of fluid, and it stuck there. And
so you basically blew up the
yes, we created with fluid. We created what you called a tamponade, and then we in the vagina. We put in another 2 gauzes, abdominal gauzes, big ones, so that we would stop it, and we put it there. And guess what? It stopped. She went to ICU, and then after ICU in the evening, that was on a Friday, she was taken back to the ward. On Monday, she was discharged.
The bleeding had completely stopped.
It had stopped. Now, I asked my colleague later on, what was her HB? Her HB is basically to see the capacity of the blood to transport oxygen. She told me that after delivery, they checked just before delivery, it was 11 grams per deciliter, which is normal. But by the time she went to ICU, it had gone to 3. So she had lost 8 grams per deciliter. Now, just to give you an idea, in order for us to replenish such a loss, 1 unit of blood, full blood, is about 330 milliliters, will replenish about 1 gram per deciliter.
What?
So she had lost about 2.5 liters of blood.
What?
Before delivery.
That is after delivery.
After delivery.
That's
So-
5 pints.
So the bleeding,
Yes.
the net result of the bleeding was
2.5 liters.
Okay.
2.5 liters. Now, what saved the day? The condom, as I said, the medications which she had received. She had got blood, which was available, and there was expertise on the ground. 2 heads are better than 1.
Yeah.
We have done this. Now, can we do this?
And it's all just, trying something. Try this, try the other. Of course, informed trial.
Yeah, we know what exactly is supposed to happen. Of course, if she had not stopped bleeding after we put the tamponade, we would have taken her to theatre and we would have removed the womb as a last, last resort. So because it was the first time, because the thing you ask, how many times has she delivered? Once. She's a young girl, she's 30. So she may need to, who knows, she may have other plans of having her. Yeah. So what do we do? Let us try and conserve the uterus as much as possible. Does it always end up that way? No. Unfortunately. Here we were lucky, she was lucky, she was in a hospital where there were medications, there was blood, there was personnel.
Yeah.
Most of the women who die in our countries, unfortunately, they end up in hospitals where there are no medications, there is no blood, and sometimes the personnel, qualified personnel, is also not available. Let's look at the numbers, just to give you a rough idea.
Yeah.
Mandera County, maternal mortality rate is about 3,800 in every 100,000 women who deliver. In Wajir, it's about 1,700. In Turkana, it's about 1,200, about 1,630. And so on. Migori has about 603. Kisumu about 506. When we do an average, we get that in Kenya, the maternal mortality rate is about 362 in every 100,000 women that deliver. Actually, when we quote some of these
100,000 live births.
in every 100,000 live births, 362 women will die, unfortunately. So that is equating to 1 woman dying every day.
What's a global average?
Yeah. The global average now depends on what we are talking about. Because if you look at the so-called developed countries, their MMR rates are about 10, 12. When you go to Scandinavian countries, it's about 4. You go to the UK, it's about 3, 4, 5, in every 100,000 women. Yesterday, I was reading an article that in the US, actually what is happening is that their MMR rates have started creeping up from around 20. they have reached around 30, and it is principally because they are closing obstetric hospital units in some of the states, in remote parts of some states like Idaho, and other states. Why? Because they don't have personnel, qualified personnel who are able to manage these pregnant women right from the beginning and all the way until delivery, and take care of possible complications that can happen during childbirth.
Did you get to find out what was causing this complication with this particular
in this particular patient?
Yes.
No, because because there is a certain way we look at things when we are in such a situation. We start by analyzing to see whether there's any tissues which have been torn, and there were no tissues which have been torn. You look at the vagina, look at the uterus, look at the cervix, and then you go into the uterus, whether the uterus is contracted. Most of the time, the uterus may not be contracted because of different reasons. You may find that the lady has delivered a big baby, for example. Maybe she has delivered twins. Maybe she is coming back to deliver maybe for the 5th time, for the 6th time. There may be some fibroids and so on. My take was that it was because of the fibroid which I felt. And by the way, 40 to 60% of women of African origin will have fibroids in their reproductive period.
What are fibroids?
Fibroids is a growth. It's a growth, a benign growth most of the time. It's non-cancerous, and this is a growth in what you call the smooth muscle of the womb. The womb is formed of muscle, and as a woman develops and reaches that stage where she can start having babies, the ovaries start working and producing a hormone called estrogen. And there is a postulation that the estrogen will act on those smooth muscles, leading to the growth of those fibroids, yeah.
So there are growths that actually shouldn't be there.
They shouldn't be. Ideally, they shouldn't be there. But
so now, when you find them, what do you do?
When we find them, it will depend, because patients who come with these fibroids will. First of all, what is the reason? Most of the time, the patients come to us because of fibroids is because if they are big and they have symptoms which accompany them. And the symptoms can be, for example, feeling heaviness in the lower abdomen. They may feel pressure symptoms, especially when they go to short call. When they have their short call, they feel as if they haven't completed the short call. They go back, and then after a few minutes they still go back, and whatever comes out is not commensurate to the pressure that they are feeling. Sometimes there can also be pressure during the long call, so they have the same feeling. I feel like going for a long call, but when she goes for a long call, it's as if nothing much is coming out, but the pressure is still there. And heavy bleeding. And some of these women can actually bleed terribly. You may find a woman, during her periods, she uses packs. For us gynecologists, we know actually all the sizes of these packs that they use. So we ask them, how heavy are your periods? You say, I use maybe 4 or 5, packs of maxi packs. That is a lot of bleeding.
That's a lot.
A lot of bleeding. And some of them actually say, but Daktari, I use this and I use another towel sometimes on top, but still there is leakage, and there could be clots as well. So when a woman comes and we ask some of these questions, and these are some of the symptoms that we get, we generally have an idea about what we're dealing with. And then when we do an abdominal examination, we'll actually find that the uterus is quite enlarged. And when you do a scan, we will see that there is a problem.
Back to these numbers.
Yes.
You've given us, for example, Scandinavian countries, the UK, 3 to 4 deaths out of 100,000 live births.
That's right.
In the US, you said now it's an issue because they're getting to 30.
Absolutely.
Oh my goodness, that's a big issue. In Kenya, our average is 362.
Yes.
That also does not create a picture, because Mandera, 3,800 women are dying every year out of 100,000 live births.
Out of 100,000.
Out of 100,000 live births
Yes.
are dying. This is a very huge number. Why would this number be so high? The second highest, Wajir, 1,700, is about half.
I will quote somebody. I can't remember exactly his name, but he's a gentleman from Egypt, who was also an obstetrician, and who said women are dying not because we don't know why they are dying. the reasons why they are dying. Women are dying because we know the reasons for high maternal mortality rates. They are the so-called the big five, where we have PPH, which is postpartum hemorrhage, that is bleeding after delivery. We have what we call preeclampsia, that is the blood pressure, increasing, especially after the second trimester or during the second trimester. We have sepsis. We have obstructed labor, and then we have post-abortion complications. So we know the reasons.
These are the five main reasons.
Those are the five big ones, which are obstetrical. There can also be other non-obstetric, for example, if you have HIV, malaria, especially now that the rainy season is here, and so on. Those can also contribute to maternal mortality rates. So what this gentleman said is that women are dying not because we don't know the reasons for their dying. Women are dying because we have not made a conscious decision that their lives are worth saving. We have not made that decision, that their lives are worth saving. So when you look at those numbers, Mandera, Wajir, Turkana, even if there were 506, or even if we take the average of 362, it is a huge, huge number. We have not made a conscious decision that their lives are worth saving.
Really?
Yes, we have not. Why? Because look at it this way. Imagine that was the example that I gave was in a private hospital, well equipped. We have all these medications, all of them. Whichever medication
and an available ICU.
There was an ICU which is available. There is there were three consultants, two consultant obstetricians and gynecologists, and one very experienced anesthesiologist. So whatever you would ask, you say, this has been done, this has been given. So what do we do next? Let us do this. There is a cascade sort of way of doing. And we managed to have, because of a simple condom. Now, you will find in public hospitals, because that is where majority of our women deliver, you find there is no condom. You find there is no that pipe. It's a pipe called a Foley's catheter. It is not available. We talk about medications, what we call oxytocics, meaning they're the ones which help in contracting the uterus. They are not available. Or you find that some of those medications are there, but the quality is poor. So you give a patient, you expect a reaction. It is not happening. It is not happening. So what is happening? 3 weeks ago, I was in a meeting with the Ministry of Health and some stakeholders from some counties. I think it was about 10 counties. And basically, we're talking about the same problem. How do we source for these medications? How do we source for these commodities such that they are available in every hospital, every level hospital where a woman actually is delivering? We find that the people who make the decisions usually are not in the front line. They don't use these medications. They don't see these patients who are undergoing this. So it is us to tell them, you know what, we need this and this and this and this available. But for them, it's like we didn't know that actually this is what is happening. So somebody sits in an office and says, we will take this medication only. This is what we are going to order. But then the question is, what if when you use that medication, it does not work? We need to have alternatives. The other issue is blood. Blood is a big, big problem. In this country, on average, we need about 500,000, units of blood, such that we are comfortable and that we are able to take care of everybody who needs blood, whether it's pre-surgery or post-surgery, whether it's patients who are having cancer or patients who we are talking about today. But unfortunately, we get about maybe about 150,000 units, or even if we say 200,000 units, there is still a huge shortfall. And the blood is actually one of the biggest components, especially when a patient like our patient, the one I mentioned, lost 2.5 liters of blood. What happens is that the body now stops, what we call coagulation stops working, because what we call factors which lead to coagulation are not there, creating another problem altogether.
Every time one talks about maternal healthcare, it seems to be the discussion revolves around the problems around it with regard to the majority of the population in the country.
Yes.
Meaning the very fundamentals of that care are not available to the people who actually probably need it most. Now,
unfortunately.
yes. So now, we are saying, now let me ask the question, are we saying that we don't have adequate personnel in the country? Not in the regions where they're needed, but within the country?
Yeah.
Yes. And I'm talking about the entire cascade of healthcare providers that you need to provide the optimum care for the person who needs it. Or are we saying that irrespective of the training needs that our institutions seek to meet, somehow the planning and implementation of healthcare provision doesn't quite gel with the available personnel who are actually there within the country?
I think it is both.
Yes.
I'll start with the first one. Still going back to example that I gave, there were medications, there was blood, there was personnel. Let's go back to these counties that we are talking about. You'll find that medications may not be available. Personnel is a very big issue. And number three, there are other additional factors which come in. What are these? Look at it this way. Mandera possibly has maybe one or possibly two consultant obstetricians, or maybe none. There's a time where Gyna had only one consultant obstetrician in the whole county. There was a time Turkana had 4 consultant obstetricians in the whole county. And then the interesting thing is that, all these are my colleagues. I know them. One of them went for further training to become an oncologist, gynecology oncologist. One of them was given a job in the county government, but nothing to do with health. One of them resigned and went to do some other work and training, and they were left with 1 out of 4. So issues of manpower. So now you wonder, even if there are 5 or even 10, in a county like Turkana or in a county like Garissa, for example, which is quite vast, if a complication does happen, where will this consultant be found? Will he be at the northernmost part of the county, or at the southernmost, or in the middle, or wherever you'll be? So there is a challenge with manpower. Talked about training. We have a reasonable number of consultant obstetricians, because by and large now we are about almost 500, which is not a bad number. About 500. About 500 in the country. In the whole country, we have about 500.
We have about 1 million live births in Kenya every year.
Thank you. Now, out of those 500, there are those, of course, there's the natural attrition, which is happening every year. And there are those ones who will say, no, I don't want to do this. Let me go and subspecialize and do something else. So we are left with a certain number. Now, obviously, after going to school and training for so many years, you need a certain level of lifestyle. Let's call it that way.
Yeah.
You will find that in some counties, you may not be given that chance, or if you are given that chance, you are given, okay, come, we will employ you as a consultant, obstetrician and gynecologist, but you'll be so frustrated because you will not have the tools that you need in order for you to be able to work. There are no medications, theater is not working, you may not get this, and so on and so forth. So there is that issue of distribution of manpower. Now, out of these about 500, the big cities, Nairobi has the most of the consultants, followed by Mombasa, Kisumu and Eldoret, and now these other ones we have, a few here and there. What do we need to do in terms of asking about the manpower?
The solution. Hold on. Hold that thought. We'll go to the solution after this. Let's take a break. It's 24 minutes to 10. Dr. Kireki Omanwa is the president of the Kenya Obstetrical and Gynecological Society, and he's here because we are discussing the high maternal mortality rates in this country. When he said that 362 women out of every 100,000 live births are dying, this is a very high number. And it's very high because it's over 300%, not very, very many percentages higher than the global average. And this is just the average. Dr. has told us in some counties, it's actually thousands of women dying. This is a very high number. What is it that we need to do? Let's discuss that after this break.
This is the Situation Room, the only way to start your day.
We are still here with Dr. Kireki Omanwa, the president of the Kenya Obstetrical and Gynecological Society, giving us those grim figures of the number of women who die while giving birth. And this is uncalled for. In fact, Dr. you've quoted another person from Egypt who said that our women are dying not because we don't know what's killing them, not because we don't know that they're dying, but because we have not made a conscious decision that they are worth saving.
Their lives are worth saving. Yes.
That is so damning.
Yeah.
So what do we do, City?
You know, is that not the eternal question? What do we do? But I would ask a question which isn't eternal, but in my mind gets to the heart of the matter. Why don't we do what we really know we ought to do? Because we actually can. It's not that we can't do what needs to be done. We can. You see, perhaps the discussion about the preventative aspect of healthcare and how it is we can actually plug into it in every which way we can would be the way to start. Because it's something that involves educating, training people at whatever fundamental level within our society so that they understand certain things.
Absolutely.
And so that these large numbers actually are reduced. Now, the specialized care that is necessary, we all know that it comes with horrendous costs, okay? But the primary health care, remember all these discussions about universal health care and what it can do and what have you. If you have a system like that actually works, and you actually have hospitals that have commodities and have personnel, then everything becomes a lot simpler.
Yes, absolutely.
Yes.
And those numbers will drop.
They will drop.
They will drop.
So
They will drop. Yeah.
And sometimes I would dare argue that without necessarily a very huge increase in the budgetary allocation that the ministry has, because there's what the government gives the ministry, and there's what the partners give. And they are colossal amounts. If I look at, say, the amount of money that, say, for instance, PEPFAR has given Kenya for HIV, which covered maternal health care as well,
Yes.
over time, it's 860 billion Kenya shillings. Now, surely, that is enough money.
That's a lot of money.
Yes, it could have overhauled the healthcare system in the country. It's
Absolutely.
a great deal of money.
So where did the money go?
Isn't that now the eternal question? Where does our money go? Because every time someone tells you this money isn't enough, and you ask a simple question, can you tell us what you've done with the one you got?
Thank you.
So that we can see where the gaps are. That story now becomes grey, vague, and you ask unnecessary questions. Surely, you know the money was you. So,
Give us more.
yes, exactly.
Give
And
us
then when
more.
you're given more, it's the same story. I am saying this. There are healthcare professionals. They are health economists. There are people within the health fraternity, health sector, who, believe me, know exactly what needs to be done.
Absolutely.
Now, the question is, how do you get enough pull to make sure that those who, not even just the purse strings, the power strings, those who have them, listen and actually get these things done? Because having people who know what to do, we have an abundance of those.
But you see, I still go back to that quotation, that we have not made a conscious decision that their lives are worth saving. Why do I quote that again? Because the lady who's delivering in level 3 hospital, in a level 4 hospital, who is quote unquote nobody because she's not affiliated, she's not known to anybody. Of course, when it comes to are the medications there, whether they are there or not, it's really neither here nor there. But when it touches somebody who is in a position of making serious decisions and say, look, Allah, it even happened to my family, so we have to make a decision. Now, why do I think and why do I insist that we have not made a conscious decision? It is because if, for example, there was a conscious decision that everybody in this country, including our civil servants, including our ministers, MCAs, etc., have to use the public health system. It would be overhauled in one day. The money would flow to the public health system. We would get all these commodities. We would get all the workers, the human resource that is needed. And believe you me, these numbers would drop, like at a drop of a hat. So we have issues with that. We don't have this, or the money that comes in. Kenya as a country, we sign up to so many, conventions. We have the Sustainable Development Goals, number 3, whereby we actually, the government signed that by the year 2030, we should have reduced our maternal mortality rates to 70 in 100,000. Obviously, that is not going to be possible. We are only 7 years away, and looking at the numbers, they don't look good. We have this. The government signed on to the Abuja Declaration that we should have an incremental allocation to the health budget until it gets to about 15% of the total budget. It is not happening. It has not happened. I don't see it happening soon. So this is why I keep on saying that we have not made a conscious decision that the lives of these mothers and other Kenyans are worth saving. And then it's also paradoxical because we enshrine this in the Constitution that everybody has a right to quality health care and as well as reproductive health care, and then we do something completely opposite.
Is it possible that these numbers are invisible?
They are invisible, unfortunately.
Like we don't see them because, as you talk about, I'm still thinking, just Mandera County, what's the population of Mandera County? 3,800. How many live births do we get in Mandera County? I mean, if this is a very high number, if you just look at it, but you don't hear it. You don't hear it from even the people in Mandera. I mean, because it will be an issue. Even communities, if it was visible, you'd be feeling the pressure from communities coming out and saying, no. The number of women who've actually died in this hospital, is it an issue about the hospital? It will be starting from community not understanding, but now just accusing the doctors or the hospital or the facilities and saying, this hospital is killing very many of our women and they're coming to give birth. We don't hear this.
It is because there are other factors as well.
Right.
There is the faith factor that comes in and says it has happened. Shauri ya Mungu, hatuwezi kufanya chochote. So that also does have an effect. But again, going back to what we are talking about funding, about personnel, about availability of commodities. And then there are other factors as well. Because, for example, we have what is called the 3-delay model, whereby the first delay is where the patient makes a decision at home. I need to go to hospital. And for example, if she's bleeding or she has whatever it is, that decision may take time. And then there's the second delay. The second delay is from home to the hospital. How does she get to hospital? Are there roads? Is it safe for her to travel in the night? etc. And then the third delay now is in the hospital. She has arrived at the hospital. Is there personnel? Are they well trained to do the right thing in such a situation? Now, let me start with the third delay. We are in hospital and we have this. Kenya, I think we know about this. We have several thousand doctors who are unemployed.
Yep.
Several thousand doctors in a developing country.
Trained and unemployed.
Trained by our money because we pay taxes. And the training takes many years. They have decided that we are going to be doctors for whatever reason it is, but they are there and we are producing more. And we are not employing them. Are we serious with life? I don't think we are. Not only doctors, they're also nurses as well. And we are happy to say that, now because our health personnel are very well trained, they can go and work in the UK and they will send money to Kenya.
Yeah.
Are we serious with life?
We can export our health.
We can export our health. Yet, it's like saying my house is burning, but let me go to the UK and then I'll send somebody to come and help, sort out
Put out
this
the fire.
Really? the numbers are invisible. Why are they invisible? They are invisible because health is not visible. A healthy population, you actually don't see it. It is not the roads that we see. It is not the buildings that we see. It is not the schools that we see. It is not the piped water that we... etc.
It's not tangible.
Yes, all of these which are basic needs. But the most important of them is health. Imagine if we kept our young girls in school. Research has shown, there was a paper I was reading the other day from Peru, that for every 1 year that our girls stay in school, we actually reduce the maternal mortality rate by 29.3 in every 100,000.
Wow.
For every year we keep them in school. But we have over 200,000 adolescent pregnancies, which we are not talking about, or it doesn't bother because it is not me. Ni mtu mwingine tu huko. It is not me. We are not talking about the harmful practices, of FGM, because one of the big fives is actually what? Is actually obstructed labor. And again, remember we talked about Mandela, we talked about Wajir, we talked about this. This is where FGM is actually very, very prevalent.
Yeah.
And they do the worst sort of FGM, what we call infibulation, where they cut everything, the clitoris, the labia majora, labia minora, and they leave just a tiny opening.
And they sew it up even.
And they sew it up. We had during our Congress in February, we had a lady who came up. I think she was from Isiolo or Marsabit, and she gave her experience. It was a horrible, harrowing experience. She had undergone FGM when she was 6 years. And then when she was 12, the parents decided, no, that was not enough. They went back and they removed everything. And guess what? It was not in hospital. What they used to suture the tissues together was actually thorns. So they put the thorns there, and she was in bed for 1 whole month. She could not do anything. When she was talking about it, I could actually feel the pain. Even now, when I remember about that, actually, it is something which is horrible. But this is happening in this country. And because of that, she ended up having 5 cesarean sections. And one of the issues that cesarean section is a major surgery. And she could have easily lost her life in any one of these cesarean sections. So these are some of the things that we need to talk about. Community knowledge, some of these harmful traditional cultural practices are also, also add up, to some of these problems that we are having of maternal mortality rates.
Post-abortion complication is also one of the big 5.
Yes, it is.
That means abortion.
That means abortion.
Most of the time it will be backroom abortion.
Absolutely. We had a case of a New Year. I was on call, and my registrar called me and said, we have this patient and we opened the abdomen and we can't seem to find our way around it. So I came and we looked, and actually it was quite complicated.
Just pause. When you say you couldn't find your way around it.
Yeah.
Okay, explain the complication.
Okay. We opened the abdomen. Ideally, you're supposed to, because she came bleeding, and she had a fever of 40 degrees Celsius. So something must have happened. Of course, she gave the history, but she didn't tell us the whole story. But as we go in, as I call us forensic, doctors sometimes in such cases, the complications that we have, first of all, we could not open the abdomen properly because the gut were all matted, seriously matted. I thought that possibly there could have been a perforation. So as we are opening slowly, I asked for my colleague, a surgeon, to come also to help us just in case. But at the end of the day, we managed to actually open, and dissect the gut slowly. And what happened is that we found out that there was a perforation at the posterior wall of the uterus, the back wall of the uterus. Now, again, because the way our bodies have been created, the body sort of limited the extent of the infection because of a serious infection, and she had about 1 liter of pus in the abdomen.
What?
1 liter of pus. That is why the fevers were going to 40.
What?
So we drained the pus. The whole theater was stinking like, whatever it is.
Yeah.
Anyway.
Like no one's business.
Yeah, no one's business. We cleaned her up, but then unfortunately we had to remove one of her tubes because it was completely destroyed. The other one was completely blocked. We managed to clean her up and everything was okay. 19-year-old girl.
What had brought this about?
And that is what because she was, I found her in theater. So the following day I found her in the ward. So I asked her, so what happened? And she said, I just started bleeding. I said, really? When was your last period? She said, there was a period of about 8 to 9 weeks without a period, which basically means that you're either pregnant or something is happening. And obviously she had a backroom abortion, and whoever had done it had perforated the uterus, and thank God it had not gone into the bowels because we could have lost her. 19-year-old. Now, 19-year-old, we have removed the tube. The other one is blocked as well. So by the time when she wants to get a baby, unfortunately there'll be serious complications because she won't be able to have a baby naturally. So there we go. These are postpartum. And by the way, abortion or illegal abortion are not procured only by young girls. They are also procured by ladies who are married, ladies who have children, and so on. So that is also another problem as well.
Hey, a lot needs to happen. There is a lot of awareness that we need, and thank you very much, Dr. for coming, because this is a conversation that ought to happen all the time.
Absolutely.
Like I said, it's invisible because we also don't talk about it or we hide it, all this kind of, but I am sure nobody knew the extent of the danger that this girl had gone into.
Of course nobody
When she went back home, it's like, alikuwa tu hospitali kidogo.
Alitokwa na damu kidogo akapelekwa theater, lakini sasa yuko sawa.
Sawa, tunashukuru Mungu.
Nana meza dawa.
Tunashukuru Mungu. And that story ends there.
Yes.
And Dr. thank you for joining us.
Asante sana.
Always a pleasure. Dr. Kireki Omanwa is the president of the Kenya Obstetrical and Gynecological Society, and he's been here. We've been talking about maternal mortality rates. We need to keep these ones addressed.